There actually is a lot of anatomical fact to what Martha was alluding to, and I've learned a tremendous amount just from listening to Martha and how it correlates with recent research. So the orgasm in spinal cord injuries, yes, that is anatomically entirely feasible, as is the location of the G-spot, etc. So I shall try to shed some light on these aspects. What I will not be able to help you with is deciphering the mystery of the female in general. That is beyond my ability. Fortunately, it's fun that way. So, when we down to spinal surgery, there's a number of structures which are at risk. Most of these which you know. There's the sympathetic chain, the superior hypogastric plexus, and the inferior hypogastric plexus. Now, traditionally, these have been strongly divided. Recent research shows that there actually are one continuity. So there's a plethora of fibers with different transmitters, and the classical division between sympathetic and parasympathetic does not really hold true anymore. And I'll go over these structures one by one, pretty much. So the general anatomical location concept is that the superior hypogastric plexus is located left to the aortal bifurcation. It is usually a concentration of bundled fibers, and then once the superior hypogastric plexus passes down into the pelvis, it divides into the left and right hypogastric nerve. Now this is what this looks like in reality, and I don't think we have a pointer, do we? No. So the vessel structure which you see, I can't point to it, in the middle is the bifurcation of the aorta, and you see the slightly lighter shade is the hypogastric plexus passing over it and the division of fibers. So these are really intimately adherent to the vessels in many aspects, and it is not always easy to bluntly wipe these fibers aside. Now, recent research has shown that the structure of males and females with regards to the superior hypogastric plexus actually is identical. So we have the same configuration of the ovarian ganglions, left and right, or the male equivalent being the spermatic ganglions, and these embryologically are the same for males and females. So the structure generally is the same. And the important aspect in these are these two structures which I'd like to point out. And this is something which has been highlighted in recent publications. These are the lumbar-splanchnic nerves. Now, the lumbar-splanchnic nerves are fibers which emerge from the thoracolumbar junction together with vasopelvic connection. So it actually is a connection from the vagal nerve all the way down the spine. Now, these have been highlighted in this image here, and these lumbar-splanchnic nerves are these strands which you see occasionally. I'll just pop over to this slide, or basically you can see these splanchnic nerves passing the discs on the image to the left. These are fibers which we often cauterize in spinal surgery. Sorry, I just didn't have to do this. So these are the discs. This space is here, and these splanchnic nerves crossing across the aorta in front of the spine. In the absence of a pointer. These splanchnic nerves transmit pre- and postganglionic fibers into the hypogastric plexus and the superior hypogastric plexus. So they do quite imminently transmit information. Once the hypogastric plexus passes down into the pelvis, it forms the hypogastric nerve. Now, the hypogastric nerve then divides into fibers which go right down to the genitalia, the internal genitalia. So there is a strand of fibers which merges from the hypogastric plexus all the way down to the genitalia, and which is joined by the pelvic splanchnic nerves. Now, if you look closely in the diagram, you will see these fibers emerging from the S2 usually to S4 foramen, and these additional fibers join the inferior hypogastric nerves. This is a publication which a lot of research has gone into through vaginal banding for incontinence, and people found there were sexual disturbances when passing these bands, and I'll go into these in some detail. Now, the inferior hypogastric nerve, therefore, consists of pelvic splanchnic nerves, which have cholinergic fibers, which are partially parasympathetic, but also sympathetic fibers. Now, these fibers are responsible for detrusor contractility, so the bladder contraction, lubrication, and swelling of the genitalia. The superior hypogastric nerve contains fibers which are primarily sympathetic, but also some parasympathetic fibers, which have all the mentioned functions with the lubrication, etc. So when we looked at the glands which Martha mentioned, these fibers are what are responsible for the lubrication, etc. And all these fibers are found in the anterior of the spine. Now, if you look at this in greater detail, this is an image of the clitoris with the cruise of the clitoris, and you can see how the fibers from the superior hypogastric nerve innervate the clitoris. The fibers emerging below this band, you'll see a certain number of fibers coming from inferior, that's the pudendal nerve. So the clitoris is duly innervated by the pudendal nerve, which also has a motor function for the anus, which I'll go over in a moment, but also the parasympathetic and sympathetic nerve innervation. Now, these nerves do not all carry normal sensory fibers. This means stimulation of the clitoris will have a vegetative result without necessarily there being a subjective sensory input. And this explains in part why you have these orgasms in spinal cord injury patients. So these pathways exist. These fibers also converge in the anterior aspect of the vagina, where the urethra passes across the anterior wall, and they form the basis of the G-spot. So these fibers actually do condense in this area, so there is an anatomical correlate of this. This is an immunohistochemical study, and the green fibers are these sympathetic and parasympathetic fibers where they join the pudendal nerve, which is the yellow fibers, and the blue structure is the cruise of the clitoris. So this is where both of these fibers merge, and this goes a long way to describing many of the effects which Martha was mentioning. So just assuming that the innervation is merely by the pudendal nerve is a greatly simplified description of the internal genitalia. So clitoral erectile function is often nitrous oxide positive. So this is what causes the swelling, and this is where the vasodilating creams we've heard of have their function, also why Viagra has an effect on females as well. And the nerve which communicates with the pudendal nerve is the so-called cavernous nerve. So these are small fibers which actually coordinate the secretion and also the female ejaculation, which we heard about, and work synergistically with the dorsal nerve of the clitoris. Now, what this means in spinal surgery, and I'll come back to this point in a moment, is if you have a spinal cord injured patient, this is something which I learned literally 15 minutes ago from Martha, which made me think. If you have a spinal cord injured patient who still has some residual orgasmic function or sexual arousal function, the last thing you really want to do is do very extensive dissections of the anterior part of the lumbar spine. So that could have a deleterious effect, something which I've never thought about. So the pudendal nerve is the most commonly referred to nerve, and it divides into three parts: the perineal nerve, which provides us with a normal objective sensation; the inferior rectal nerve, which controls the the external anal sphincter; and the dorsal penis or clitoris nerve, which provides the mixed innervation, which we've just described. This whole constellation is very complex, and when you go into the different types of neurotransmitters, it becomes very, very complex to understand. In a rough approximation, the superior hypogastric plexus is responsible for the efferent bladder closure and transmission of pain from the uterus and fallopian tube, which is why paravertebral blocks of the hypogastric plexus are effective in patients with cancer pain of the pelvis, for example. And the inferior hypogastric plexus, with the innervation, the contributions from the pelvic splanchnic nerves of S3 and S4 are really those which are responsible in a more direct manner for erection and the more direct sexual functions. Now, bladder closure. This is where a lot of the considerations about anterior surgery have arisen in retrograde ejaculation of the male. So how does that work? Our selfless colleagues in Bern, our urology colleagues, have done self-evaluations during orgasm and ejaculation as to the pressures, and they found a very impressive 5-meter H2O pressure during ejaculation, which is quite remarkable, and this is due to the closure of the bladder neck. And this is what allows anterograde ejaculation. So in the normal physiological state, what happens is that the suprahypogastric plexus fibers close off the bladder neck, there's a pressure gradient, and you get ejaculation. What happens is if you've disrupted these fibers is that the internal sphincter, the proximal vesical sphincter, dilates, and you have a pressure gradient which goes the other direction. So hence you get retrograde ejaculation. There's a theoretical correlate in women, and theoretically you can get incontinence or you can get bladder impairment during sexual arousal or during intercourse, and this theoretically would be a correlate of this, and I believe Irene's going to be talking about these matters in greater detail. So what this means for us, and this is an image of a multi-level ALIF in a judental scoliosis patient, just to show the amount of dissection you do. There's the common iliac vein and artery stretched across the L5 vertebra, effusion device below, and to above there's a remnant of the sympathetic chain, and all the other fibers pretty much have been stripped off the spine. So this is the situation which we are causing, sometimes unavoidably. And maybe that one unilateral innervation may be enough, but it's something worth bearing in mind that actually we are disrupting more than we think. And this can lead to a retrograde ejaculation in extreme cases, rarely, but it can do. Urinary urgency and incontinence, it can rarely lead to erectile dysfunction. And of course, it can explain, as from Martha's presentation, impaired lubrication and tumescence. And all these are very rarely talked about. So in conclusion, this leads up to Irene's talk. The superior and hypogastric nerves are anatomical constructs of one continuous sympathetic and parasympathetic structure, which has a continuity to the vagal nerve and sympathetic fibers as well. The detailed structure and function is complex, and there still are many unknown variables. And the lumbar-splanchnic nerves are vulnerable, especially at L4, L5, and L3, L4 levels. And I've ignored these, I've just transected these, but it may be worth trying to prevent these. And the effect on sexual function is probably greater than expected, and this is what Irene has been looking at. Thank you very much for your attention.